So hello, everyone. Thank you so much for joining. We have a really great turnout. My name is Audrey, and I'm the Public Policy Engagement Facilitator for the School of Life and Medical Sciences based in UCL Public Policy in the Office of the Vice Provost for Research, which is a very long title. Another part of my role in my free time, I'm an author for Cochrane, which produces evidence-based medicine systematic reviews, and I'm a member of the Cochrane Early Career Professionals group. So I'm delivering this training today, sort of sitting across two roles in both my systematic reviewing capacity as well as my public policy capacity. The training slides today are based off of the slides that were developed by the WHO, the World Health Organization. So it is rapid reviewing methods in the context of health systems. However, the methodologies are applicable across all policy spheres and domains. So just because the examples today will be more health focused, the methods themselves are easily transferable to your domain. So that's a little bit about myself. So I have both a systematic reviewing background and a policy background. So first off, I'm just going to cover what a rapid review is and the need for these in health policy. Screen, the answer to the first question, what is a systematic review? 72% of you were correct. It's a summary of all the available primary research in response to a research question. Often I do get a question about what the difference between a systematic review is and a literature review. And the main difference is that a systematic review will follow scientific, reproducible, and transparent steps to conducting the review. So in theory, if someone else followed steps as you, they would get the same results. Whereas a literature review is less scientifically based in methods and is less rigorous. The statement which is false, again, very happy with the group, impressed with your knowledge here. So the false statement is that it's simpler and requires less planning. So even though the name is rapid, it does actually take quite a bit of planning in order to make the steps that you're doing more efficient, but we'll cover this later. So what is a rapid review? It's a type of knowledge synthesis in which the steps of a systematic review are streamlined or accelerated to produce evidence in a shortened time. So the key message here is that in the policymaking world, policymakers often need and request evidence to plan, develop, and implement health policies. So we've seen this a lot in the ongoing COVID-19 pandemic, how there has been a greater emphasis within the government to be basing their decisions or to be guided by some of the science. So systematic reviews are increasingly used to inform policy decisions and to provide guidance, yet the production of a systematic review often takes a very, very long time and are misaligned with decision timelines. For example, most systematic reviews may take a team 2 years to do, whereas a decision-making timeline, you might need, a policymaker might need evidence within a couple of weeks or even a couple of days. So rapid reviews have emerged as a useful way to provide actionable and relevant evidence in a timely and cost-effective manner. And there's different types of rapid evidence products. So there's an inventory, which is kind of like an annotated bibliography. This lists all of the evidence that's available on a topic, but does not appraise, summarize, or synthesize any of the evidence. There's also rapid briefs. So these provide a summary of the best available evidence. Synthesis is conducted and it's contextualized within the decision maker or the policymaker's question. And they're known as knowledge translation products. And they'll often base their evidence and the findings on existing evidence from systematic reviews. And then there's rapid review, which is a knowledge generation strategy. So just as with the systematic review, the principles of the knowledge synthesis process still hold for generating a rapid review. Rapid reviews follow scientific methods, reproducible methods, and are transparent. So next, I'm going to cover the steps that you'll typically follow in performing a rapid review. I apologize if this section is a bit technical. Again, in the resource document that I'll be circulating, I provide resources for additional training that you'll be able to follow at your own pace. So it's really important if you're conducting a rapid review that you engage with the research requester from the very beginning so that they can help focusing the rapid review and ensure that it's appropriate for the needs of the stakeholders. So while there are various streamlining approaches for each step of the rapid reviewing process, the caveat is that in streamlining, it does raise into questions validity of the conclusions from a rapid review. So sometimes the conclusions are uncertain. So in terms of the validity of conclusions of a systematic review compared to a rapid review, the systematic review findings will be more certain, but again, more costly, much more resource intensive, and take a lot longer. So you need to be able to find a balance between conducting your rapid review within the time frame available while making it as rigorous as possible. And whatever you do, whatever steps you decide to take, you just need to be transparent about what sort of shortcuts you've taken so that the stakeholder knows exactly what went into the rapid review and what didn't. So first of all, the first step in a review is to do a needs assessment, select the topic, and also refine the topic. And so it's really important, again, that you work with the research requester to really figure out what the purpose is, what the scope is, and what kind of timeline you have. It'd also be really important to conduct a preliminary literature search just to see what evidence is out there, see what kind of scope you can do, and inform the conversations. So when I'm doing this, I'll often just go on Google Scholar and do a quick search around to see what's available. It's also really helpful to see if there's any systematic reviews that have been conducted in the area, because if you have a systematic review that specifically already answers your questions in terms of the populations and the interventions, there's no need to reinvent the wheel if a product is already available for you to use. The next stage in the review process is protocol development. So this is when you're deciding what your population is, your intervention, what your outcomes are, so how you're going to measure the effectiveness of the intervention, and the data analysis and synthesis processes that you'll be using. So there are standard protocol tools such as Prospero that include a rapid review term. And the literature research, so typically many rapid reviews, if you're in a sort of health or science field, will use databases such as PubMed, the Cochrane library to look for systematic reviews, or Embase. And you should search at least 2 databases. If you only search one, that means what you're developing is some sort of more like a literature review. So in your search, ensure that you're searching at least 2 databases. Now, this is one part that you can really make your reviewing process lean. So what you can do is you can imply English language searches only, or the languages that you're fluent in, instead of collecting studies in all languages and then requiring you to get a translator. So you can limit to English. You can limit by country. So this way, if you're only looking at a UK context, then there's no point in getting studies from, say, South America. And commonly, you will not contact authors. So with a systematic review, you'll often search through the bibliographic references and follow up with authors, but with a rapid review, you just don't have time to do this. There's a question asking how many existing studies do you need for you to decide that it's worth conducting a rapid review or an update of a past review. So there's really no hard and fast rule on this. It really depends on your research question, because there are some areas that just don't have any studies, or you might even only just have 1 study, and that's fine. It's also fine to have an empty review, because sometimes it's just as important to show that you systematically looked through all of the literature and you found nothing. So that is also still worth publishing, because it shows that there's a really, really important research gap and a research need, and it should encourage funders to fund research into this area. So unfortunately, I can't give you a specific answer here, but in terms of updating a review, if say you found a systematic review from 2010 in a relevant area, but obviously 10 years has passed since then, what you can do for the update is just run the search from 2010 to 2020. So you don't have to do all of the work all over again. You're just updating the search with that area. But if it's say 2 years old and the policy area hasn't changed that much, there hasn't been that many big changes in the area, if you think it's still relevant and if the stakeholders think it's still relevant, then you're able to use that as well. But it's really a consideration of what your research question is and sort of the policy context. And there's another question about asking why only using one database means it's no longer a systematic review. So the goal of a systematic review is, in an ideal world, you would search every relevant database to find any study that is relevant to your research question that has been published. And so often databases don't carry all of the papers in one area. They might be cross-referenced across different databases. So if you only search one database, like Embase or EBSCOhost, there is a large risk that you'll just be missing out on relevant studies. So that's why even if you're doing a rapid review, a minimum of 2 is needed. So the next stage, after you've collected, after you've run your searches across the databases and you've got the study, so you have 1,000, 2,000 searches, then what you need to do is screen them to see which ones are applicable, and you screen them against the protocol that you would have previously developed. So this stage, traditionally, you would do it dual blinded screening. So 2 people would independently screen all of the studies, and then you would compare differences. But with rapid reviewing, what you might want to do instead of dual screening is have a colleague and yourself do dual screening of a random sample of say 10% or 100 of your study hits. Make sure that you have a high degree of agreement, so around between 80 and 90% agreement. And then if you've reached that threshold, then you can just carry on with the screening on your own. The resource document that I'm providing includes a list of the softwares available that can help you with each of these steps. So you don't need to do it all manually in Excel or Word files. There are specific information science resources available for you. After you've chosen the studies that are relevant and are going to be included in your review, you then need to extract the data. So that's when you're pulling out all of the information that will go into the evidence synthesis. So again, there's software that can help you with this, or you can just use Google Sheets or Google Excel with columns for the different areas of the data that you'll extract. Traditionally and commonly with a systematic review, again, you would do this in dual. But for the essence of time, with a rapid review, you might just have one person doing this. Risk of bias assessment also, with a systematic review, assesses the quality of studies. But you might skip this step with a rapid review. However, if you do have the time, it is encouraged that you do a risk of bias assessment. This way, the stakeholders and the policymakers can have an idea of how good the evidence is that they're basing the recommendations on. The knowledge synthesis part, now normally, if you might do a meta-analysis if you have a lot of studies in a systematic review, but with a rapid review, often a narrative synthesis is more common, so instead of a meta-analysis. So a narrative synthesis will just pull out all of the relevant outcomes and summarize them in table format. You can also, at this time, if you did do a risk of bias assessment, show the quality of the studies that alongside the synthesis. Then the final stage is preparing your report and disseminating this, which we'll cover in the next steps. Are there any questions at this stage before we move on about the process of doing a rapid review? And I do apologize, this was quite the whistle-stop tour. The resources that I'll provide go through each of these in a lot more detail. So rapid reviews are becoming a lot more common. So I just did a quick search on the NIHR Prospero site, and you'll see that there's all sorts of rapid reviews that have been conducted, some of them specifically in the area that are looking more broadly at health policy and practice. Others are looking at more specific interventions. There's also a question now about what the difference is between a scoping review and a rapid review. So a scoping review, you'll often do it at the outset of a project just to see what evidence is available. The goal of a scoping review is not to find all of the available evidence, it's just to get an idea of what's been done. It might give you an idea of how to frame your research question, how to frame your search. Scoping reviews very much sort of frame how you want to then proceed with your research, whereas a rapid review does still attempt to find all of the existing literature and database. So a rapid review will be a lot more in-depth than a scoping review would be. So the next part of this presentation will be about engaging with policymakers and decision makers in the conduct of a rapid review. So in this context, a knowledge user is defined as an individual who's likely to be able to use the research results to inform decisions about policies. These might include policymakers, civil servants, MPs, people who work for policy think tanks. And you want to tailor the level of engagement to the available resources and the objectives of the engagement. So you might have different objectives for why you want to engage with your stakeholders. It might be to help prioritize the outcomes, develop the framework. It might be to assist with dissemination after the research has been done, or to finalize the knowledge translation and uptake strategy. So the policymaking process, if you've attended our other training, is not linear, it's more circular, and there's many different points at which you can engage, and this depends again on your objectives. So when you're beginning at the refining and prioritizing the topic list, you can engage with your policymakers then. They can help define and develop the research question and protocol. They can help you locate literature because often these stakeholders are content experts in their area, so they might be aware of really key papers that should be included. So you'd want to design your search such in a way that it would pick up those studies. They might have input for analysis or the interpretation of the findings, and I find that working with stakeholders is really important at the knowledge synthesis and generation phase because they can really put the meaning behind the numbers. They're really helpful to engage with people in terms of writing and developing the manuscript or the briefs, providing feedback, and then also working with stakeholders is really key for the uptake and the evaluation, because if you do this research and then all it does is sit in Google Scholar, I mean, that might be good for sort of in terms of academia, but if you're interested in having policy impact, then having that evaluation and the uptake is really critical. So obviously during the pandemic, in-person interaction is limited, but there's all sorts of online methods that you can use: hosting webinars, online focus groups, interviews, email communications, telephone meetings. And then we'll quickly go over the reporting and dissemination of rapid review findings. And again, if you have any questions, don't hesitate to put them in the chat. So we've covered why it's important to engage early on with knowledge users and engaging with them throughout the rapid review process, and now we'll discuss reporting and dissemination strategies. So you should put, in terms of if you're producing a rapid review, your priority should be thinking about the practical needs of the primary knowledge user, as opposed to focusing on the more traditional academic approaches to dissemination, where you might publish your paper in an academic journal, present it at a conference, etc. So the document that you produce should have some key areas. It's really important to focus on the how the evidence informs policy implications, what the findings mean for policy, focus on the results and the interpretation, and spend less time talking about the methods or sort of, the more methodological side, because the policymakers won't really be as interested in that. They don't need a detailed discussion as to why you chose the odds ratio instead of the risk ratio. Target your message to the key audiences and make sure that whichever way you choose to report the narrative synthesis, the statistics, that it's consistent throughout. It's also really, really helpful to include a one-page plain language summary. So this translates your entire manuscript into one-page, easily digestible document. And often people who are working within government, the civil service, or parliament don't have time to read pages and pages. So just having a one-page document that summarizes the key points is often sometimes all that they have time to read. Include the key messages and publication date. So this way people are able to see how relevant and timely the information is. Provide tables, and don't fill the page with text, don't cram it full of text. Make sure there's lots of blank spaces to break up the text. So now, before we go on to the case study, are there any other questions that people had about either the process of a rapid review, systematic reviews in general, or about the engagement process with rapid reviews? No, if not, okay. So I've seen that our guest, Asger, is here, and he'll be talking about a rapid review he produced for Cochrane with the WHO on ash for cleaning hands. So Asger, if you're comfortable with it and want to turn your camera on, it'd be great to see you. And thank you so much for joining us.
Okay, I'm on now.
Yep.
Perfect. Hello, everyone. I'm Asger Paludan-Müller, as it says on the slide, and I'm a researcher at the Cochrane Nordic. I handed in my PhD a month ago, so I'm no longer.
Congratulations.
Thank you. And I was the first author of the Cochrane review that Audrey just presented, looking at ash as an alternative to soap for cleaning of hands. So yeah, I'll just give a short history of the review, or what it was like from beginning to end. So the context of the review was that Cochrane was approached by the WHO and asked if they could produce a review looking into whether ash was there was any evidence that ash was an appropriate alternative to soap for cleaning hands for reducing the spread of COVID-19. And then the Cochrane Central reached out to the Nordic Cochrane Center, because we told them that we would be willing to try to do a rapid review if there was a topic that was relevant. And we had 7 days from we were told about the review till we were supposed to hand in the finished review. So it was a time frame of 1 week, which is quite short compared to what we normally would use producing a Cochrane review. So it was a pretty at first we were a bit scared about whether it was possible, but we decided that we would try to do it. And we were a group of experienced reviewers that have worked together on similar projects. So we know each other and know how we work. So the first thing we did was to sit together with some different people, capacities from Cochrane, both within the clinical field of infectious diseases and some methods people, and talk about the scope of the review, because what WHO asked was COVID specific, but first of all, we were pretty sure that there wouldn't be any studies looking at COVID specifically, and second of all, it would be we thought it would be problematic to just show whether ash worked for COVID and not other diseases, because then you might be protected against COVID-19, but not other diseases that you wash your hands to avoid. So it would be problematic to base a recommendation on only information about COVID-19. So we actually decided to look at all infectious diseases, or all bacterial and viral diseases. And I think the WHO were very happy with that. So yeah, that's also just to say that of course, we need to figure out what outcomes are most clinically relevant for rapid reviews as well as for normal systematic reviews. So we set down an author group of 4 people from the Nordic Cochrane Center we were the reviewers. We did the core of the work, and then we were so lucky to get a information specialist from Cochrane Austria to do the search strategy and to do the both searching of databases and trial registers. And I think if speed is an issue, or like the amount of time to do the review is an issue, I think that can be a really good idea, because I can probably do a pretty good search strategy that will find all that I need, but the tricky part is getting it to be specific enough. So I think by having an information specialist do the search strategy, we were able to use some filters that we wouldn't have been able to use. So that gave us less hits to screen, but also the opportunity to find the same relevant papers. So if that's an option, it's something I can strongly recommend. Of course, that won't always be an option, but it can really do a big difference. And then we on day 1 we made the search strategy and had it peer reviewed by another information specialist from Cochrane, and then Irma, the information specialist, did the search on day 1. So we had all the hits we needed to screen on day 2, and then we decided among us who screens what, and we used Covidence. I don't know if you've touched upon using Covidence.
I mentioned that there are softwares available to help you with the review processes. So what Asger is mentioning, Covidence is one of Cochrane's tools that can, where you can import all of the studies you find, and helps you with the screening process.
Yeah, exactly. So it's not, I think there are many tools that are equally good, but using some tool is probably also a good way to speed up the process, because it handles the consensus. But we did the screening in duplicate, so we were 2 people looking at each study. So it automatically handles comparing what the 2 different people have said. And so I think, again, that's a place where you can save some time by being smart about what software to use and to, yeah. So we screened the hits relatively quickly, and we had to include, because it's an understudied area. So from the start, we decided to include both randomized studies and non-randomized studies, because we had a strong suspicion that there wouldn't be very many randomized studies looking at this topic. And that turned out to be...
Sorry to interrupt. Before you started, did you do like a mini scoping search to see what evidence was out there, or did you already have a clear idea? Because I know you mentioned that there weren't very many studies to begin with.
We actually didn't do a scoping search, but I think that as I recall, this is before we were asked, but I think the WHO had told Cochrane that they knew that there weren't that many studies. At least I remember Cochrane saying that the Cochrane Central told us, we know that there aren't that many studies. So that was something we knew before we even started. And I think even though we made a very, very broad search strategy, actually, we only got about 80 hits or something, which is not that much compared to what you might sometimes get.
So that's why you were able to do dual screening.
Yeah, exactly. Because I think dual screening is definitely one of the things you could consider not doing in a rapid review. I mean, you could argue for that if you have a lot of hits, but because we had relatively few, it was, and also because we didn't have very strict inclusion criteria, it became more important to do dual screening, because it was a little more tricky to know which studies would be relevant. And we also didn't want to include a lot of not relevant studies, because that would take time later on. So in this specific case, I think dual screening was a good idea, but I think you can definitely argue that it might not be necessary in all rapid reviews. And then we used Excel online. We found out which studies to include, and we used Excel online for the data extraction, because we were all working from home at that point in time. So we had to do it online in the cloud. And I think Excel Online is just, again, one of many tools you can use for data extraction. But I think the idea of having a spreadsheet that you can work in simultaneously, I think made a lot of sense for us for this review. And I think it could make a lot of sense for a lot of reviews. Of course, there are things you have to be careful about because you can accidentally delete stuff. But again, we tried to be smart about what software to use, and I think that did save us some time in the end. So we actually also did the data extraction in duplicate, which I think sometimes you might not do in rapid reviews as well. But again, we had quite a few studies to extract data from. I think we ended up with 8 studies with any data, and most of them were, the data was just 2 numbers that we had to extract or something like that. So it was relatively quick. So we extracted the data using Excel Online, and then we used quality assessment tools. We had a few non-randomized studies where we used the tool called Robin's Eye, which is a Cochrane tool built or designed for non-randomized studies of interventions. And then we used Risk of Bias 2.0, also Cochrane tool for 3 randomized trials we included. And again, we did it in duplicate. And again, I guess that's one of the things you could argue whether it's necessary, but I think that's probably one of the things I would say was, for us, it was good that we did it in duplicate because we actually had some disagreements and it became better. So I think it depends on the topic area and how experienced people are, but I would say that risk of bias is probably one of the things that I would recommend doing in duplicate if it's possible, but it depends on the context, of course. Yeah, so far, I think in our study, or actually all the way through, there were not that many things that we did that were that specific for rapid reviews. The process was very similar to what we would do for systematic review. We didn't cut that many corners. One corner we definitely did cut was the protocol, which was not really a protocol like we would normally do it in Cochrane, which is a very extensive paper it's a paper in itself, and it's published and peer reviewed. For this study, we just had a template that Cochrane had made where we would fill out what study designs to include, what population to include, what intervention to include, and what comparator to include. And I think it's very important to still have a protocol of some type where you pre-specify what to do. But I think it's a good idea that if you are pressed for time and you have to get results out quickly, that you can do it in a form that's not so neat as what we would normally do. It's not that important that it's well written and it's very elaborate. It's just important that people can go back and see, did they do what they said they wanted to do? So I think that made a lot of sense to have a template and just fill that out and have that approved.
Formed a narrative synthesis instead of like a statistical meta-analysis. What was the reason for that?
Well, we didn't. We had a few studies where we could have done meta-analysis, but we had a lot of different outcomes that it was unclear how similar were. So one study looked at infections that were self-reported and not clinically diagnosed infections, but just asking people, have you had symptoms of an infection for the last 2 weeks, I think. And another study looked at people coming into hospitals with diarrhea, we didn't think it was appropriate to synthesize those 2 outcomes together because they are 2 different. So the main reason for not doing a meta-analysis was that we just didn't think that we had any data from studies that were comparable enough to do it in an appropriate way.
And then I know when we were talking before the seminar took place, when I'd asked about sort of your engagement with the WHO and the policymakers, you'd mentioned that it was a little bit limited, probably because they were so busy managing the whole pandemic. But could you talk a bit about how having more engagement with the policymaker might facilitate the process of the development?
Yeah, I think that would definitely have been a good idea, but of course it was difficult because they were really busy, and when we had to do something so quickly, it was easier for us to not to just dig down and do the work. But of course, if the work that's getting done is not what the people who needs to use the evidence need, then it doesn't really matter. So for future reference, I would say that we would have to be more. It made a lot of sense that it was WHO contacting Cochrane and then Cochrane contacting us, but it would have been nice if we had had some kind of contact person in the WHO, I think, so we could clarify the scope they were interested in a little more. In this case, we kind of just had to guess, or not guess, because I think we used some, but estimate what is the most likely that they would be able to use. So we had to think, well, we think it's mostly relevant to look at all infections, not just COVID. But it would have been good to talk to the WHO about that. And so, yeah, I think that's a good lesson, that's some of the things you have to be mindful about when you're doing something quickly, that it's still very important that you're on the same page, so you don't end up with a product that doesn't match
Exactly.
the needs of, yeah.
And I think this transitions well into sort of the final part about the key takeaways, where you had mentioned that it would have been important to have greater interaction with the policymakers. Did you want to just go through sort of the other key takeaways?
Yeah, so I think good team dynamics was a really, really important thing for us. So as I mentioned, we had a very, very short deadline of 5 to 7 days, which I think is shorter than most rapid reviews would have as well. So then just not have it's just easier that it's people that you've worked with before that you know very well, so you don't have to, there wasn't any, we didn't have to be diplomatic about it because we know each other. So if we disagree, it's easy to disagree. We know what each other mean a little more intuitively than with new people. So I think that was very important for this specific thing. Then on the other hand, it does have the slight drawback of not being able to include people from outside who might have other points of view. So I think that's like a balance that you have to find, that it's working with people you know, and people that you know you work well with can be really good, but you also run the risk of repeating the same mistakes. So I think it's good. This was actually quite good because we did have some outside help, both from Cochrane and from some context area experts. So we did the bulk of the review, but then we had a very short, not a real peer review, but some methods experts from Cochrane looking it through and sparring with us very intensively over 24 hours, which took what we've made, which was pretty good, and then we had some outside help to look at it, and then it became a lot better. So I think that was a pretty good way to do it. Which is also, I guess that's one of the key takeaways here, that editorial support throughout is a lot more efficient than having to normally when we do a Cochrane review, it's more, you do a lot of work, then you send it to the editorial unit, they take some time answering, then they send it back to us, then we have to find time to look at what they send. So that process becomes a lot slower than having a more constant flow of information back and forth. So yeah.
That's great. And I think it's also worth mentioning that for those of you who aren't familiar with Cochrane, so Cochrane produces systematic reviews on sort of any topic related to health. And the typical review, if everything goes well, which often doesn't, is 2 years. So the fact that Asker and his team was able to put together a very methodologically rigorous rapid review in, what was it, like 5 days?
Yeah, then there was some peer review. So from day one to publication, I think it was a month, but we sent our first edition to the WHO after 5 days.
And I think, as Asker mentioned, that 5 days is a little bit out of the ordinary. Even with a rapid review context, they probably wouldn't be asking for something that quickly, but you might have like a month or 2 months as opposed to a year.
Yeah.
So are there any questions for Asker about the rapid reviewing process or any tips if there's any questions. Oh, there's a question asking how big your team was.
Yeah, that's a good question. We were 4 people doing the bulk of the systematic reviewing, and then 1 information specialist. So 5 people. And I think there's a balance between, of course, more people can do more work, but then there's also it's also inefficient to have too many different people doing. So
Too many cooks in the kitchen.
Yeah, exactly. I think 4 or 5 people is probably, for many cases, a pretty good number of people, I would imagine.
There's another couple of questions asking, are the tools that we've mentioned, like the checklists and the software like Confidence, openly available? And yes, they are. So all of the checklists, you can easily download all of like the critical appraisal checklists in the software such as Confidence, RevMan, Rayan. All of the ones that I list in the resource document that I'll circulate are free. There's another question, and I'm very glad you asked, about how you can get involved with Cochrane or to learn more about systematic reviews as an undergraduate. So the Cochrane Early Career Professionals group that I'm a part of is trying to foster a community of people in evidence-based medicine who might still be students. There's lots of free training available on the Cochrane website. There's also a platform called Task Exchange. So that's where people who are working on big reviews, if they have tasks like extracting data or going through study selection, they'll post these on the board as kind of like a free job board. And then people, you can pick up those tasks to do, or often there's translation tasks. So if you speak another language fluently, you can help with translation. So it's a really great way to sort of get your foot in the door and to find out more. And again, in the resource document, I'll provide some more links for you to check out. There is also just a quick question about how ASH actually works for cleaning hands.
Yeah, that's a relevant question, I guess, talking about a review. Yeah, so what we found out, which is in a way disappointing, but also a very real finding, is that there's no evidence to suggest that ASH works or that it doesn't work. The few studies that do examine it are too high risk of bias, and they are not looking at clinically relevant outcomes. So what we conclude and what we send to the WHO is that given the available evidence, it's not possible to say anything about ASH's effectiveness or the harms of using ASH as an alternative to soap. So what I would say based on that is that it would be pretty dangerous to recommend using ASH as an alternative to soap without available evidence. So probably better studies should be done before we could make such a recommendation. But of course, recommendations, there's some politics to that as well. So yeah.
Yeah, and I think it's important to mention that sort of within the policy sphere that it's not just about the science, it's also the context and the politics that surround that. And also, I think researchers might be sort of hesitant to publish a paper that says there aren't any clear findings, but I think it's actually safer and it's important that people do. Otherwise, policymakers might be basing decisions that could actually have unintended negative consequences. So if the finding is, if the overall conclusion is, there is no certain evidence, that's just as good as saying that there is.
Yeah, absolutely.
Well, thank you very much, Asger, for joining us. I really appreciate that and having that sort of case study and very timely topic as well, given the current situation. Just in the last couple of minutes, I wanted to talk about how you as a researcher, how researchers now can get involved with rapid reviews and how the UK government is taking up rapid reviews. So each government department has published an area of research interest. So these are key research questions or topics that they're interested in. And this way they want to align science and research evidence from academia with policy development and and decision making. So they often engage with researchers and academia to develop these areas. The Parliamentary Office for Science and Technology, POST, they produce impartial, nonpartisan scientific research that informs UK Parliament. And they cover everything from biology to social sciences and everything in between. So what they've done recently is that the POST published 20 COVID-19 areas of research interest. And they also have a COVID-19 repository. So if you're working on research currently that's related to COVID-19, you can update the repository with your information if any of it answers any of the research questions, or if you'll be shortly carrying out research in this area. Another really interesting thing that you can do with the POST areas of research interest is that if you're putting in a funding bid or a new proposal, submitting a grant application, then you can cite that you've aligned your research to the needs of Parliament. So it might just add strength and strengthen your application. So I'll include the link in the resource document, but you can see that the 20 areas that they're looking at really cover every area from economic viability, education, resilience, mental health, and so on. So it really is cross-cutting. And for those of you who are interested in learning more about Cochrane and rapid reviews, you can check out our website, or you can sign up for our monthly newsletter. And we host things like journal clubs, training, and online meetups for people who are interested in getting more into the systematic reviewing world. I also just wanted to highlight that UCL Public Policy is here to support you. We offer funding for small grant schemes for policy engagement. We offer fellowships, including for people who are PhD students or who are still completing their degrees. We also provide advice and training if you want us to look over part of your funding bid. We're happy to do that. And we also can provide ad hoc support.